Hello, everybody, and thank you for tuning into another interview on the Art of Intervention Project Summit. Well, today we get the pleasure to speak with Assistant Secretary Elinore McCance-Kratz, and she is over at SAMHSA. And if you don't know what that is, you are getting ready to find out, because it's an amazing resource for families, loved ones, professionals, basically the entire world to tap into what's going on out there. So, Dr. McCance-Kratz, would you feel free to introduce yourself?
Sure. So I'm the Assistant Secretary for Mental Health and Substance Use. I lead the Substance Abuse and Mental Health Services Administration, or SAMHSA, and I'm a psychiatrist. My specialty is addiction psychiatry. I've spent much of my career providing treatment to people mainly with opioid use disorders, cocaine and alcohol use disorders. I've done a lot of research in medications development. I've done a lot of work kind of at the interface of HIV and substance problems, particularly opioid problems and injection drug use. And I've done a lot of work with the government. So here I am at SAMHSA and talking to you today.
Well, I appreciate it very much. And I'm sure you've seen the landscape change quite a bit over the last period of time that you've been in the industry. And we want to talk to you about the resources and how to get people on the right track. And so why don't we go ahead and start with, what can people expect for treatment resources for opioid use disorders?
Sure. So in terms of thinking about opioid use disorder and treatment resources, I think that it's really important to make clear that everybody's different. And so there's not a one size fits all for the treatment of opioid use disorder. When you recognize that opioid use has become a problem, that you need some help with it, there are some questions that need to be asked and answered to get you to the right treatment. So one of the first questions is going to be, do you have a physical dependence on opioids? So opioids are drugs that can make people get to a point where their bodies actually are what we call dependent on the drug. And what that means is, if you can't get that drug, if you have to reduce the amount of drug you're using, your body will tell you in a way that you're not going to like that you need more opioids. So you're going to feel withdrawal symptoms, you're going to get anxious, you're going to feel your heart beat too fast, you might get some high blood pressure, you're going to get sweaty, you're going to get cramps, you're going to get muscle aches. It's going to be really unpleasant. If that happens, that puts you in a direction of getting treatment with a medication. Now, once you know that, you got to determine what kind of medication is acceptable to you. What is it you're looking for? And so for many people, they will say, I'd like not to be on opioids at all, okay? If that happens, there are ways that those of us who provide addiction services, we can medically withdraw you from opioids. There are some medications we can use to help you become free of opioids. Now, if you're somebody who has had a problem with relapsing illness, you really need to be on a medication. And that medication in that situation would most likely be something we call injectable naltrexone. Naltrexone is a drug that's an opioid antagonist. So you're not going to get any opiate effects from that medication. It's a once a month injection. And what it does is, if you were to take an opioid, it would block the effect of that opioid. And so that gives people, what that really does is that gives people time to get back to treatment, to talk to their clinician, their therapist, their counselor, to get their family and friends to provide them more supports and to help them figure out what's going on, that they're relapsing to opioid use. Now, if you're a person who has not done well with medical withdrawal, let's say you've had deep medical withdrawal, some people call it detox. If you've had that, and you've relapsed more than once, you might want to think about what we call an opioid pharmacotherapy, medication-assisted treatment to help you to stop withdrawal symptoms and stabilize so that you don't have to use opioids throughout every day, and to help to address craving so that you can start to process again what it is that is involved with your use, your addiction, and how to get back into recovery and on with a normal life. Now, there's two medications for that. One is methadone, and that's a medication that that has a number of uses. It's actually approved as a treatment for pain, but it's also approved as a treatment for opioid use disorder. If it's used for opioid use disorder, the only place you can get methadone is from what's called an opioid treatment program, or what we in the old days used to call methadone maintenance programs. Now we call them opioid treatment programs. And what those will do is provide you methadone in a safe environment, and also the psychosocial treatments and recovery supports that you need to address the opioid problems that you're having. The other medication is called buprenorphine, and it's usually given as buprenorphine naloxone. That is a medication that comes in a number of different forms now. So you can get it as an under-the-tongue tablet, you can get it as a film, you can get it as a quickly dissolving form that you put in your cheek, inside your cheek. There are also long-acting forms now. You can get a month-long injectable medication. Depends on what you think you need to help you in your recovery, and your clinician, your therapist, your counselor should be able to help you make those decisions. The thing about buprenorphine is that that is available by prescription. So you can get, if your doctor has a special waiver that allows them to prescribe this drug, you can get this medication from your doctor in a prescription, and you take that medication in the privacy of your home, which is different than starting methadone. Methadone, you usually have to go to the clinic every day until you get well stabilized. Then you can get some what we call take-home medication. With buprenorphine, generally you're taking that medication at home from the start. You decide what is going to be best for you if you've got that level of problem. Now, the other thing is, for a treatment of opioids, you're going to need what we call psychosocial supports. So medication addresses withdrawal symptoms. It helps to address craving. It's not going to address some of the problem thinking that you have that contributes to your risk for relapse and ongoing substance problems. That is going to require counseling. A lot of times, family therapy to rebuild relationships. It's going to require you learning, so what we call education around the problem substances. Toxicology screening, important, not because anybody wants to say, oh, you did something wrong here, but because it helps us as clinicians to understand what the problems are and what do we need to do to be best helping the person. So all of those things need to happen. And then the third part of the treatment for opioid use disorder is going to be community recovery supports. And in community recovery supports, we usually think about peer support. So people who've experienced problems like you're having, who know a lot about it and are in the community and there to help you with that. Help with childcare so that you can go to your appointments for your treatment. Help with housing. Some people have problems with the legal system. These kinds of supports are available in the community. And what we try to encourage from SAMHSA, where I work, we try to encourage clinical staff to work with community recovery support staff to make sure that that person gets the total care and treatment that they need. Those things are all important. Now, let me also say there's a few other things that are important that people should be thinking about. And that is that it's actually rare to, at least in my experience, to see someone who doesn't have other issues, be that other substance problems. Very, very common to have alcohol problems, possibly stimulant problems, marijuana, very, very common these days. Tobacco use, very common these days. All of those things will make it more difficult for you. If you keep using those substances, make it more difficult for you to recover from opioids and contribute to other physical health problems. That's another piece of this. Often people with opioid use disorder are going to have physical health problems they may be aware of. So if you're injecting drugs, it's not uncommon to get what we call cellulitis, infection under your skin. It's not uncommon to get an abscess at the place where you're injecting. It's not uncommon to get, unfortunately, very, very serious diseases, such as infection of your heart, endocarditis. These kinds of problems can be quite common, but also you may neglect your other parts of your physical health. Some people aren't even aware that they actually have hypertension. It needs to be treated, that they're pre-diabetic and they need to pay attention to that. When you get into treatment for your opioid use disorder, those things should be addressed, and the person should get a treatment plan that addresses all of these needs. And then the third part is that it's quite common to have what we call co-occurring mental disorders. So sometimes people who have a problem with a substance will also develop mental health issues. It could be an anxiety problem. It could be a depression. It really could be any kind of a mental disorder, and a person needs to be screened for that, again, because treating an addiction will not treat a mental disorder. Treating just a mental disorder will not treat a substance use disorder. And people with these problems, in my experience, they have complex co-occurring issues that we need to pay attention to in order to give them the best possible chance for a healthy recovery.
Yeah, that is a great description. Thank you so much. That was very thorough, and I know our audience will learn a ton, because a lot of this wasn't available years ago, or maybe it wasn't as prevalent as a method to get people help. So what I like hearing is this is not a moral issue, as a lot of people think, like, well, just stop. It's not a moral issue for people. And do you see a difference in the opioid use versus substance use as far as treatment goes?
So yes and no. So for opioids, in some ways we're fortunate because we have medications that are FDA approved. They've been shown in multiple research studies to be helpful to people that have developed an opioid use disorder. For other kinds of substances, we don't have those medications available. So I'll go through those in just very briefly so that people get an idea of what's out there, because I've often found in treating my own patients that they're not aware of what the different types of treatments are. So as I mentioned before, alcohol problems, pretty common, very commonly co-occur with opioids and other mental disorders. Very common to have an alcohol component to that. Alcohol is one of those drugs that we do have FDA-approved medications for. Now, I will tell you that most people do not get access to these medications. There's a couple of reasons for that. One is that people don't know about them, so they don't know to ask their doctors for them. But also, doctors aren't aware of them. And so it's really important. And one of the things we do at SAMHSA is we do training for healthcare professionals and for the public on these kinds of resources so that people know what's available and what they should be asking their clinicians about. For alcohol, there's several different medications. There's a medication, so naltrexone, I mentioned it for opioids. In the case of opioids, it blocks that opioid effect. In the case of alcohol, it helps to reduce craving. If you're a person who has both an opioid problem and an alcohol problem, you may want to try injectable naltrexone because it'll get at both of those issues. You can't use naltrexone, by the way, if you have an opioid problem and you're taking an opioid. If you're taking buprenorphine or methadone, naltrexone off the table for alcohol. So that's something to think about. We also have a drug called acamprosate. Acamprosate is a medication that can be started once somebody has been medically withdrawn from alcohol. And by the way, I should mention that for a lot of people, alcohol also produces physical dependence. The physical dependence it produces is different from that of opioids. Both very uncomfortable withdrawal syndromes. But with alcohol, unfortunately, people who withdraw from alcohol are at risk for seizure disorders. And for very severe cases, something we call delirium tremens, sometimes people know it as DTs. This can be life-threatening. People die of this. We don't usually see people die of opioid use disorder withdrawal unless they have other conditions that are out of control. But for alcohol, you need to get the right treatment if you're going to come off of alcohol and you're physically dependent. This is no small matter. So this is important. Now, once you come off, acamprosate is a medication that can be started that helps to reduce craving and reduce the relapse risk. And then there's a third medication that's also FDA approved, very old medication. It's called disulfiram or Antabuse. Now, this is a medication that when you take it, what it does is it interferes with the metabolism of alcohol by your body. And so you will get unpleasant effects if you drink alcohol while you're taking Antabuse. So again, decisions about what medication works best should be the individual's choice. Our job as clinicians is to work with people to help them to make the choices that are going to be most helpful to them. Again, with alcohol, psychosocial treatments are going to be important. When we think about tobacco, and I like to mention this because we don't hear about it enough in the world of treating substance use disorders. I've heard people say, can't take away somebody's cigarettes too. I mean, they're already giving up all these. Well, here's the thing. All of these drugs, be it alcohol, be it opioids, be it tobacco, be it stimulants, they have what we call a common pathway in the brain to the pleasure center. If you keep with tobacco, that's going to put you at risk for relapse. No fault of your own. People don't know this. It's going to put you at risk. And we know that tobacco problems are much more common in people with mental and substance use disorders, and they kill. They kill in large numbers. So I want people to get treatment for tobacco problems. And there are a number of FDA-approved medications for that. Again, you can use a drug like, it's called bupropion. It's an antidepressant medication. It's also used to treat tobacco dependence. So if you had both depression and tobacco dependence, you might want to look at Zyban or bupropion. If you're a person who just has a main problem with tobacco and you've tried many times to stop and haven't been able with just supports, you may want to try varenicline or what's called Chantix. So that's two medications. The other that is very commonly used, and the nice thing about it is you can buy it over the counter, you don't need a prescription for it, is there are large numbers of different types of nicotine replacements. But let me tell you what we don't know works, and that is vaping. So I just want to mention that some people, when we heard about vaping, when it first became common in the United States back in the early 2000s, the idea was it was going to help people to stop smoking. We now have research data that shows that some people start with vaping and go on to start smoking cigarettes. So we don't have strong evidence for vaping being a treatment for tobacco dependence. So I think it's really important to make that point to people. Now, medications that don't exist for other types of substance problems, and they're very difficult problems. And so one of them is marijuana. Marijuana is so as states liberalize their marijuana laws, okay, as they make it much, much more accessible. And in some states, there are more marijuana dispensaries than there are CVS and other types of pharmacies. So it tells you something about the popularity of marijuana.
Oh yeah, I'm out in Colorado, so I know exactly what you're talking about. Yeah.
Okay. So as that happens, we will see more and more people who will develop use disorders with marijuana. And of the illicit substances, and from our vantage point at the federal level, regardless of what states do, marijuana is an illicit substance. It is the illicit substance for which there are the most people with use disorders. Over 4 million Americans have a use disorder. And as a lot of times people will start saying, I'm going to use this for some medical issue, which, by the way, there are no medical issues for which marijuana, the botanical, has been shown to be effective. Lots of data on that. So as that happens, they may get into a habit that they may not have intended to have happen, and they develop a use disorder. All of a sudden, they find themselves having to use marijuana every day. and use it more often than they were intended to use it. And it interferes with their ability to get things done, go to school, go to work. That's an issue with marijuana, and we don't have a medication for that. The other category of drugs that are very problematic are the stimulants. So that would be mainly cocaine and methamphetamine. For these substances, again, we don't have medication treatments that are effective. And that's very difficult, especially for methamphetamine, which we are seeing big increases in some parts of the country, big increases in methamphetamine use. And what goes along with that are medical problems, mental health problems, that really will need attention in and of themselves. So with stimulants, one of the therapies that may be useful is something that we call contingency management. So contingency management is an intervention where you basically provide some small rewards for the behaviors that are helpful to people in recovery. So people who stop their use are able to get some rewards that just make it so that they're more motivated to continue on that path. The amounts of reward are small. We actually, at the federal level, we have a situation where we're looking at whether we can do more in the way of contingency management. I hope those changes will be made. They haven't been made yet. Right now, it's just small rewards. But that has been found to be very helpful in a number of different situations. So when you reinforce the behavior you want, it's easier to get people to do that. And then they sort of start on that path themselves, and they see the benefits in their lives, and they continue it. So these are difficult problems. But I do think it's important to also just again reiterate what you said earlier. These are not moral issues. These are not moral issues at all. There are for substance use disorders, there is genetic vulnerability. A very large amount of the risk of substance use disorder is based on your genes. What's happening in your family. You could take a look at your family, and you may be a little concerned, like, oh, can that happen to me? That may make you a little more aware of what potential risks are. But genetics play a big role. Being in an environment where the drugs are easily available is another risk. And the problem is that once somebody gets involved with drugs, it can just spiral out of control quickly. So no, this isn't a moral issue at all. This is a change in your brain chemistry produced by these drugs that then sort of hijack you. So, so we can help, and that's what we want to do at SAMHSA. We want to help providers to provide the very best possible care and hope for people who are entering what is a difficult process, but which can be done successfully.
Well, your website has a plethora of information on it for people that I know I use it a ton as a professional as well for education, to find treatment centers in certain states. And it is an amazing resource. And do you have a couple minutes to talk about what you've seen in the COVID world happening? And we can touch on that for a few minutes if you have a little more time.
Sure. So the COVID situation is one that is very concerning. So there are things that we're seeing that cause us great concern. The first thing I'm going to preface all of this by saying is that when you initiate these stay-at-home orders, these lockdowns, basically you're taking people out of their work environment, their social environment. You're telling people to do things they've never had to do before. Stay at home, don't go out, school your kids at home, just get by without your usual job, and you don't know where your finances are going to come from or what's going to happen. These are extraordinarily stressful situations. And so we see some things happening that concern us greatly. One is that we know that the rate of alcohol use is greatly increasing. Now, in many states, in many states, liquor stores have been closed. In some, they're essential. Go figure. But also with stay-at-home orders, right? Restaurants aren't ordering alcohol, and yet we're seeing huge increases in alcohol being ordered and home delivery of alcohol. So what happens is people, they're bored, they're anxious, they're depressed. Some experience this is very traumatic, and they may drink. They may drink. And they may get into trouble with alcohol. They may binge drink. They may develop a physical dependence, and people don't even know that that can happen. So that's one thing that concerns us quite a bit. We're seeing huge increases in calls to our disaster distress helpline, and we know that most of those are related to concerns related to COVID-19. We know that emergency department visits have decreased overall from a year ago. But if you look at the percentage of visits to EDs that are related to suicide attempts, that actually has gone up. And what that tells us is that the lethality of suicide attempts is going up. So we're very concerned about what's going on. We also know from the scientific literature that quarantining people for as little as 9 days can have long-lasting effects on mental health in terms of depression, anxiety. Anger is a big problem. Trauma and development of post-traumatic stress disorder type syndromes. It's little as 9 days. Nobody knows. Nobody's ever locked people down for 2 months plus. So we're in uncharted waters in terms of what might be the mental health and substance use fallout of COVID. But I'm pretty sure it's going to be substantial based on just these numbers that we're seeing and based on the scientific literature.
Yeah, thank you for sharing into that, because that's something that people aren't used to. It's kind of like your spouse used to be at work all the time, or your significant other right now they're home and you're like, man, you drink a lot, or you're really kind of
Yeah.
rude, and domestic violence is up, and
Yes.
all these things too. So what would you say to people watching right now or listening? And again, whether it's a year or two down the road and COVID's not happening, it doesn't matter. Our issues are still there. That is on this fence of like, I need help and I don't know what to do.
Sure. And that is such a true statement because again, some of the things that have happened in this time of COVID is that it's not easy to get a face-to-face appointment, right? Because we're not supposed to go out, and because the healthcare providers have been told not to have usual appointments. It's hard to get a doctor's appointment. It's hard to get a dentist's appointment. It's really hard to get a mental health or substance use disorder evaluation and services. One of the things we've done at SAMHSA to address this is to make telehealth more widely available. And so, and this was actually a pretty heavy lift, because on the behavioral health side, our folks, our providers, were not big utilizers of telehealth. Just not something, when we provide care, we like to be with people. That's how people best get treatment, is by being with their clinicians, being with others who share those similar issues and working together in a therapeutic way to address them. So we had to, at SAMHSA, one of the things we did was we made national training available. We have had over 500,000 providers who have gone to our website to get information about providing telehealth and taking courses. We provide these courses free at no cost because we want people to be able to access treatment during this time. So that has been very successful. We've gotten a lot of positive feedback. Patients seem to like it. It's a way that you can have that contact. If you need a prescription, you can get evaluated and get that prescription, even by telephone. That was also a heavy lift, because telehealth is actually described as being an audio-visual, sort of like what we're doing, an internet-based service. But the fact is that millions of Americans either live in rural areas and don't have access to internet, or they don't have the means to have internet access and computers in their homes. Should they not be able to get services? Absolutely not. We're going to make sure that all Americans can get services. And so what we did was we advocated strongly for use of the telephone. And now the Centers for Medicare and Medicaid Services are paying for all telehealth, including use of the telephone. We will try to keep that in place. We did this as part of the emergency, the public health emergency, but I can tell you I will be talking this up and trying very hard to keep that in place because Americans need this option.
That gave me goosebumps. That's really cool that you did that. So thanks for all your advocacy work, everything that you do. And we're just grateful to have you a part of the Art of Intervention Project Summit. Do you have any parting words for people?
I just want to say thank you for giving me the opportunity to speak. I really feel like in government and in science, we spend too much time talking to each other and not enough time talking to people, real people who have these issues and have trouble getting the information they need. And I just want to end by saying, if you need help with a substance problem, go to findtreatment.gov. That's if you don't, there's also a helpline you can call that you can get referred to services. But if you have internet available, go to findtreatment.gov. All you have to do is put in your city, your zip code, and you will get information about the services that are available. And we want people to get that care and treatment. That is what people need to live healthy, productive, happy lives. And that's what we want. That's what we want for our people.
I will say this, so when you go there, y'all, it's the amount of options you have to drill down is phenomenal, where you can put, inpatient, outpatient, age. There's so many options right there that you can drill it down to even your specific niche. So people that are listed on there have listed all their benefits and things that they do too. So I think this is amazing today, and I wish you the best in your efforts. And I'm a big fan of SAMHSA. So keep up the great work, Dr. McCance-Kratz, and we just really appreciate you participating. Thank you.
Thank you. Thank you for the opportunity.
You got it.
Bye-bye.